Alrighty, well, good afternoon and apologies for the delay in starting. I'm Sherry Lang, currently serving as the Acting Chief Medical Officer here at CMS, and I'm really delighted to bring this topic to you today. And the title of this is An Ounce of Prevention for a Healthier Nation. And I think what we will hear about is how can we as individuals really take action to create a healthier nation. That means we are also taking care of our own health. This is a very actionable opportunity, I believe. We will be addressing the following learning objectives, that by the end of this activity, you should be able to recall that prevention should be the nation's top health policy priority, recognizing that prevention requires shared responsibility. We all own a part of this. We need to also recall that the urgency given to the nation's current health trends and be aware of where we are on that curve, and finally recognize that federal leadership, we can catalyze state and local efforts. And all of this actually does align with CMS goals of empowering patients and clinicians to make decisions about their health care, ushering in a new era of state flexibility and local leadership, supporting innovative approaches to improving quality, accessibility, and affordability, and finally improving the customer experience, CMS's customer experience. Now, we often refer to customer experience, but to be very, very clear, this is about the beneficiaries who we serve and also the clinicians who provide care and services for our beneficiaries. We are accredited for CME and CEU approval, so we support educational activities that facilitate quality improvement and events that enlist healthcare providers as partners and collaborators in achieving common goals, that is, of a healthier nation. We also have credit and recorded enduring materials through the Medicare Learning Network that is available for viewing even after conclusion of today's event. There will be both live and enduring materials will have instructions on how to access the presentation and also receive CME and CEU credit for participating. I will ask you that there is a sign-in sheet at the desk on the outside, so on your way out, if you could just log in your name, that would be enormously helpful to us. These materials and the events are available through this location and link. So as with other Grand Rounds events, this event is really prepared as a public service, as a service to, and our chance at CMS as staff to get together and hear the latest cutting edge and receive the information that then can inform how we do our work, and so that our work has the highest fidelity possible relative to the latest and emerging evidence. And we do have plans for a future event in April, but that date actually may change. So keep an eye on your calendars. And with that, I'm actually really honored and delighted to welcome back Dr. Anand Parekh. Anand is a collaborator and friend who previously supported HHS's development and integration of principles and care for people with multiple chronic conditions. So this was work that he started while with the Office of Assistant Secretary. He is now the Chief Medical Advisor of the Bipartisan Policy Center in Washington, D.C. Hello, dear Tricia. Welcome, Anand.
And we've got us plus SMEs.
Sherry, thank you so much, and thanks to everybody who's here today. Nice to see some familiar faces. I know quite a few people are also watching. Great to be back at CMS. As Sherry mentioned, I was at the department from 2005 to 2015 and had just a lot of great experiences working with CMS on many different issues, from value-driven healthcare transformation to the work we did on multiple chronic conditions, to standing up the Prevention and Population Health Model at the Innovation Center. So a lot of great memories here, and thanks to all of you for the work that you all do on behalf of the American public every day. I know many of you are right now involved in the COVID-19 response. So a lot going on. And I'm thrilled to spend some time with you this afternoon to talk about, I think, a really important area, sort of an old topic with I think, a fresh take. And, you know, when I started sort of 20 years ago seeing patients at Hopkins, I think like many of you who are health professionals, most of the patients I saw had multiple chronic conditions. And when I left clinical practice full-time and eventually went to Health and Human Services, you know, I wanted to be the multiple chronic conditions guy. So, you know, how do you, from a policy perspective, improve the health status and quality of life of this population? And I think we did a lot. We accomplished a lot. Sherry mentioned in 2010, we launched the strategic framework on chronic conditions. For 5 years, we implemented delivery and payment models focused on that complex population, focused on enhancing research, equipping healthcare professionals, as well as supporting individuals in self-care management. So we did quite a bit focused on that population. But, you know, it occurred to me then, and still occurs to me now, that in all the years sort of both seeing patients and doing policy work, that all the conditions that we have been focusing on, most of them are in fact preventable. And one could make the argument that to a certain extent, we have been failing our patients as well as the public by not partnering with them to forestall these very conditions in the first place. And I knew that what we really needed to do was build a culture of prevention in this country. And so my talk is based on an inquiry over the last particularly couple of years focused in on prevention. And I think one could argue that CMS is positioned really to play a leading force for that, not only all throughout government, but for the society at large. Sherry mentioned sort of the learning objectives from today. They're fourfold. That we have a lot going on in health policy, but I will make the argument that prevention ought to be our top priority. Number two, prevention requires shared responsibility. That's everyone. Individuals, families, communities, business, faith-based groups, media. But I would argue that elected officials and policymakers have an absolutely critical role as well. Three, I'll talk about the urgency of this topic, given the nation's current health trends. And then fourth, this idea that federal leadership is absolutely critical to support states as well as localities. So the reason why this is a topic for grand rounds and why we're discussing this today is because the Centers for Disease Control and Prevention estimates that every year in the United States, 250,000 Americans are dying potentially preventable deaths just looking at the 5 leading causes of death: heart disease, stroke, cancer, chronic lower respiratory disease, and unintentional injury. And this is a sort of a simple study looking at the best states versus the states that are lagging, and what if all states could do as well as those best states. 250,000 potentially preventable deaths in the United States. So that's sort of the gravity of the situation. This is the urgency of the situation. I think many of you have tracked, we've all been hearing about one important population health indicator in the United States, which is U.S. life expectancy. And while in the last few weeks we did hear from 2017 to 2018 that there was a slight uptick in life expectancy in the United States, as you see from the data here from NCHS, the life expectancy in the United States was no different in 2018 than it was in 2010. So we have a lot of stagnation. If you compare this population health indicator to countries around the world, we rank somewhere around the order of 30th, 40th, or 50th. So the question is why? Why has this occurred? And the reason is that there are a number of preventable factors and preventable challenges that we're facing, from the opioid epidemic to what we call diseases of despair, suicide, alcohol use disorder, drug overdoses, the obesity crisis, as well as then what is characterized as the plateauing in the decline of mortality rates from cardiovascular disease. All of these in fact, are preventable. We know that when you peel the onion even more, that there are tremendous disparities, whether by income, and here just comparing the richest 1% of Americans with the poorest 1% of Americans. There's a 14-year life expectancy gap among men, a 10-year life expectancy gap among women. We know race is critical as well, particularly when you look at other population health indicators like infant mortality, like maternal mortality, as well as geography. Tremendous geographic disparities when it comes to population health indicators. If you look at midlife mortality, sort of New England and the Midwest having higher rates of that, and obviously southern states also doing poor on a number of health outcomes. So there are a lot of challenges here and an incredible amount that are in fact preventable. So I think when we discuss prevention, I think there are a couple of questions particularly that I get asked a lot in Washington, D.C., and I think sometimes these are the same questions that you all get asked. When we think about prevention, what we're talking about is essentially evidence-based interventions to avert, to prevent, or to detect, or to mitigate illness. So that's essentially always the definition of prevention. We know that prevention works both in the clinical setting as well as the community setting. The U.S. Preventive Service Task Force, I think all of you are well familiar with, sort of the gold standard from the clinical side. And whether it's immunizations, cancer screening, substance use counseling, these are services that have a tremendous evidence base that now also are offered to individuals and beneficiaries without cost sharing. The community guide is sort of the parallel gold standard for interventions outside the four walls of the clinical setting or in the community. And there are also a range of evidence-based community interventions as well. Those have not been leveraged by our $3.8 trillion healthcare system, but are also, from a population perspective, extremely effective. I think when it comes to prevention, we take a lot of this for granted, and I think the flu shot and flu vaccine is probably an apt example of how much we take prevention for granted. So a recent study out of the University of Florida asked an interesting question about the much maligned flu vaccine, right? And they asked the question, well, yeah, it's not a perfect vaccine. People have lots of criticisms of the vaccine, particularly when we're not able to match circulating strains well. What if we didn't have a vaccine? Would a poorly matched vaccine be any better than not having a vaccine at all? And so what they did, they modeled a poorly matched vaccine with a 20% effectiveness rate. That's pretty conservative. So if you look at the last 5 or 10 years, the effectiveness rate of a flu vaccine has been around anywhere from 19% to about 60%. Just a couple of days ago, we heard that this year's match may be at about 45%. So pretty conservative at 20%. The average uptake of a flu vaccine is around 40%, 43% over the last 5 years. And so what the modelers did is essentially they modeled a vaccine with 20% effectiveness and 43% uptake, and they compared the impact versus not having a vaccine at all. And what they found is that even with a poorly matched vaccine, there would be, or there are, 129,000 fewer hospitalizations and 61,000 deaths. That is something we don't communicate, right? That's not in our communication strategies in terms of how we communicate. Our communications are usually, well, get your flu shot, and then we hear, well, maybe, and then we hear people saying, well, maybe it doesn't work, or maybe it's not for me, or my provider said that I didn't need it. But think about how we communicate prevention messages, and I think that's absolutely critical. And I think this example reminds us of the power of prevention. So the second question that people often ask is, does prevention save money? And I think the first response for all of us when someone asks that question should be, that's the wrong question, right? We should all be talking about this topic because of the opportunity to improve health and save lives through prevention. Once you make that clear, I think, yeah, then I think it's a fair question. And researchers have looked at this and found that no different than treatments, in about 20% of the cases, yes, prevention can save lives. When you're talking about clinical preventive services, obviously it depends on who you screen and the targeting and the nature of what you're screening for. But there are a number of clinical preventive services where, from immunizations and tobacco screening and counseling, alcohol, where yes, in fact, prevention can save money. And the community setting as well, there are a range of interventions found in the community guide
that can save the maximum
money.
length for a recording.
We know from
Finish
literature,
your recording after the tone.
Healthcare, as you all know, estimated that about a quarter of our healthcare dollars in this country aren't going to improve health outcomes. If you look at ways to reduce waste, many have also focused on prevention activities as well, looking at tobacco, diabetes, obesity.
You have reached the maximum length for a recording. To send this message, press pound or hang up. To play it, 3. To re-record it, 4. To add to it, 5. To discard it, 6.
All FDA-approved smoking cessation therapies, as well as behavioral counseling,
to send this message, press pound or hang up. To play it, 3. To re-record it, 4. To add to it, 5. To discard it, 6.
Interestingly enough, what they found within 30 months, not only a reduction
Meeting
in the
is being
prevalence
recorded. Message has been sent. If you would like to try an extension, you may do so now.
For heart attacks and heart
Goodbye.
disease. Every $1 that went in the program, there's a $3.12 return, which is a pretty good outcome for return on investment in a short amount of time. Further, a UCSF recent study demonstrated that if states reduce their Medicaid smoking prevalence rate by just 1%, there would be in the following year a cumulative $2.6 billion savings for the Medicaid program. And one of the reasons why tobacco and Medicaid is talked a lot about is, as many of you know, even though 14% of adults in the United States smoke, when it comes to Medicaid beneficiaries, it's almost double. It's about 27%. So one example of how focusing on a specific prevention service, promoting it, can actually, in short order, reap savings to a mandatory program. A third question that's always asked a lot is, okay, well, prevention, okay, we understand it's about evidence-based interventions. It's about averting, detecting, mitigating illness. But at the end of the day, isn't it just about personal responsibility and individual choice? Shouldn't people just do the right thing? Or is it about policies and systems and environmental change? And through my work and through the work of many others, I think the answer's got to be both. And this is this concept of healthy defaults. We have to make the healthy choice the easy choice. And it's important to empower individuals, but it's also important to ensure the systems allow individuals to make the choices they want to make in the first place. And on this slide, you can see a range of recent, I would say over the last couple of years, and FDA led many of these activities, but a range of examples where policymakers have been able to change systems and change environments to support individuals in making that healthy choice, whether it's menu labeling regulations. You go to a restaurant these days and you can see the calories on the menu and the menu boards, and that the modeling suggests that over 2 decades that would potentially save about $8 billion in healthcare costs. That's not only because of the individual making more health conscious decisions, it's also because the industry would then sort of reformulate what's on these menu boards. As of January 1st, if you've looked at your packaged foods, now most all packaged foods have a revised nutrition facts label with added sugar information. A recent study in Circulation modeled the effects over 20 years, finding substantial reductions in both heart disease, diabetes, and savings likely in healthcare costs as well. FDA for some time has looked at voluntary sodium reductions. And this is work that started several years ago where they took 150 different food groups and set targets and said, what if we could help work with industry to reduce the sodium content in all of these groups of these targets? Within 2 years, we could drop average daily adult consumption, which is 3,400 milligrams per day right now, to 3,000 within 10 years. We can get to what the dietary guidelines for Americans asks all Americans to follow, which is about 2,300 milligrams. Again, modeling suggests substantial reductions in cardiovascular disease and potential savings in healthcare costs, and certainly cigarette package warning labels that FDA is working on. So all of these are examples where, again, if you tweak the systems, you tweak the environments, you make it it's empowering individuals not just with information, but also changing the systems around them to make the healthier choice the easier choice. And then, of course, I think over the last couple of years, we hear so much about the importance of the social determinants of health. A common question is, well, should healthcare pay for social services? You know, if you think about sort of premature mortality and how do you reduce that, you think back to the seminal studies from about 20 years ago. So lifestyle, behavior is critical, but the social determinants of health and social circumstances are right there. And there's very good evidence to suggest that in a country, the higher the social services, the healthcare services ratio, the better you do across a range of population health outcomes. So if you look at the U.S. ratio, we're at about 1 to 1. If you look at the ratio for other countries, comparable countries, they're at about 2 to 1. The difference is how much we spend, of course, on the healthcare side of the equation. When states, individual states in the United States are compared through this ratio, social services, the healthcare services, again, the states that have a higher ratio from a population health perspective do the best when it comes to outcomes. And so I think twin desirable goals in answer to this question is, on one hand, we need to increase social service spending in this country. Think about education and universal pre-K or income support and the earned income tax credit and affordability of housing. But then on the healthcare side, and more relevant for CMS, the question is, how do you leverage for the system $3.8 trillion, for CMS probably $1.1 trillion? How do you leverage our dollars to improve health? And I think that the first is, when you think about the social determinants of health, I think how we define terms is pretty important. And I think you all at CMS use the terms well, but right now in healthcare, there's actually much more attention on social needs versus social determinants of health, and that's a very important distinction, right? So if you provide home-delivered meals to a family or a beneficiary, that's a social need. Building healthy food financing or creating farmers markets, that's sort of getting at the social determinant. If you're modifying a home, that's sort of getting at the social need. If you're building affordable housing, that's the social determinant. If you're providing ride sharing so individuals can get to their clinical appointments, that's the social need. Developing community infrastructure to support physical activity, that's a social determinant. So understanding what healthcare is doing, whether they're tackling a social need or a social determinant of health, is a good place to start. So Humana, well, one of obviously the nation's leading insurers, did something interesting a couple of years ago. They launched a bold goal initiative, which was an initiative to improve the health of their members by 20% by 2020. And what they did was they selected a measure from the CDC called the Healthy Days Measure. What this measure looks at is it asks individuals over the last 30 days, would you rate your physical health and your mental health good or not good? So healthy days versus unhealthy days. How many good days, healthy days did you have versus not? And then what they did was they realized that factor, which by the way is correlated with both chronic conditions as well as healthcare utilization and healthcare costs, they realized that there must be underlying factors that are related to the Healthy Days measures. And so they studied 31 different factors, and what they found was that food insecurity and social emotional support, so social isolation, which is an important area, had the strongest link to the Healthy Days measure. And then they sort of designed interventions focused on those areas, knowing that was probably the best way to improve the measure of Healthy Days, as well as to improve outcomes and reduce preventable healthcare costs. So I think food insecurity, nutrition, obviously a really important area. Social emotional support, we're just learning more about that. We know that social isolation from a population perspective carries about a 29% risk of mortality, as well as a 59% risk of reductions in activities of daily living. But we don't really have crystallized interventions yet in that space. And so people ask me, well, what are there some low-hanging fruit of all the needs and determinants out there that healthcare ought to really focus on? I would probably say that it's nutrition and housing. And there are ample, I think, opportunities right now, as well as examples out there of entities that are focused in this space and are showing and demonstrating that you can in fact improve health outcomes and reduce costs. Some are looking at it from a social needs perspective. Some are even going beyond. You know, Geisinger's focus on food insecure, poorly controlled diabetics in central Pennsylvania. Their intervention is not just providing them diabetes self-management training and counseling, it's actually giving them food. 2 meals a day for 5 days a week, 10 meals for not only them and their families, and they've seen pilot studies substantial reductions in hemoglobin A1C. United, Kaiser, Bon Secours, these are entities not just focused on home modifications. They are actually building affordable housing. Bon Secours, just down the street here in West Baltimore, is an 88-bed acute care facility with 648 housing units right across the street from the hospital. So they have 8 times as many housing units than hospital beds. So I think both of these areas are probably what I would consider low-hanging fruit. So if those are sort of the 4 common questions, I think it all boils down, I think, and all of us have asked this question before. Well, if we all agree that prevention is important, then why hasn't it been prioritized more by policymakers? And it's been my experience, and perhaps your experience also, that oftentimes, particularly in Washington, D.C., and amongst our elected officials, the mode is often reactive in terms of when things get done. Whereas for prevention, the mode has to be exactly the opposite, right, which is proactive. Prevention requires patience. There isn't always sort of a quick win on the horizon. Even when there is, it may be invisible. You've averted something, right? So oftentimes some policymakers aren't quite sure about the evidence base behind prevention. I think that's fair and valid, and some of that is how we communicate that evidence base. For some, prevention might just be considered sort of, well, that's part of the nanny state, isn't it? Isn't it all individual responsibility? I think this argument about elusive mandatory dollars and limited discretionary dollars is a fair one, and I think it's one that we should have. So if you look at the National Health Expenditure accounts from CMS, we spend about $3.8 trillion on health in this country. About 5% of that goes to preventive services. About 3% of that goes to public health, and about 6 to 7% of that goes to primary care, which is about half of peer countries. And all 3 of these groups are not mutually exclusive, so there's a lot of overlap. I focus on these areas because if you ask the question, how do you improve population health in any country, it's sort of the 4 Ps. To improve population health, you have to focus on prevention, public health, and primary care. And this is where we're at in terms of our investments. So at the end of the day, I think we all have to really ask ourselves the question, you know, where we spend our resources reflect our priorities, and our priorities reflect our values. The question for us is, how healthy of a nation do we aspire to be? And finally, there are additional reasons why prevention probably hasn't been prioritized. We'll talk about healthcare transformation in a little bit, and how we need to ensure that prevention is part of that, and there are incentives to focus on prevention, and of course sort of a lack of grassroots movement. Whenever you're trying to do something big, you know, how do you design sort of a grassroots movement that's really pushing for this? So I want to spend just a couple of minutes going over, I think, 5 opportunities that I see, not just for CMS and HHS, but particularly for elected officials, policymakers, Congress in general. Just 5 ways, very broadly from a strategic perspective, how we could essentially make prevention a top health policy priority in this country. I think first, obviously, you know, I think from my time in Health and Human Services, I think this is from a federal perspective again, since that's sort of the lens here. This is where I would start. You know, I think prevention has to be the #1 priority for this department. Now, we talk about it a lot, but how we translate the discussions we have to actual policy, how it gets transmitted in our strategic planning efforts, in our annual budget submissions, I think is absolutely critical. Prevention needs to be thought of as part and parcel of the mission of every agency here at Health and Human Services. CDC does a tremendous job, but prevention is not just their priority. Prevention has to be the priority of every single agency here. And one could argue that CMS is actually primed to make even the biggest impact given the resources that could be leveraged from CMS and how you leverage the broader sort of healthcare sector. So I think that's fundamentally the first opportunity. So the second, I think, critical opportunity as we think about value-based healthcare transformation and quality metrics really being the currency that will take us away from paying for volume to value. The question is, how can we tweak or add to or enhance our quality metric system to focus not just on sick care, but to health care, not just on the management of chronic diseases, but the prevention of chronic diseases. And so if you look at chronic disease risk factors like tobacco use and obesity, we have currently measures that focus on smoking cessation counseling. We have measures that focus on BMI screening. We don't have measures that look at how many people actually stopped smoking, how many people actually lost weight or went from obesity to normal weight. We have measures that focus on the management of diabetes. We don't have any measures that focus on how many cases of diabetes did you prevent. We have measures focus on heart disease management, COPD management. So when you think about the prevalence of chronic disease risk factors and the incidence of chronic diseases, we don't have measures. We have not incentivized the healthcare system. We have not partnered with them to introduce what I call health status measures. Again, focused on the prevalence of chronic disease risk factors and the incidence of chronic diseases. Everything that we have is either based in this area, either based on process or management. And so the question is, how do we go from where we want to be, from where we are to where we want to be? Now, I think if you approach the healthcare sector sort of with this proposition, the first question will be like, wow, that would be difficult. That's expecting a lot from us. We may not be trained in that. That's not what we really do. But I would argue that this actually forces the clinical community linkages that are absolutely necessary to improve health outcomes and reduce preventable healthcare outcomes. Now, from a methodological perspective, and I think we'll talk about that a little bit more today, there are obviously issues that would need to be talked about, whether it's adverse selection or cherry picking, whether it's risk adjustment. And all of these, I think, are important issues. And it could very well be, at the end of the day, if these are introduced, they're introduced in a way where there's a positive incentive as opposed to a negative incentive. But at the end of the day, again, if we want to move from a sick care to a healthcare system, we need to focus on preventing the chronic diseases driving the costs in the programs that we serve, as well as we need to focus on the prevalence of the risk factors driving those chronic diseases. And it is time that we focus not just on the management of these, but we focus on the prevention of these. So there's been some movement in this direction. So recently the National Quality Forum and their Measures Incubator Program teamed up with AMGA and Discern Health, and they looked at obesity. And here is sort of a sample that's, I think, still out for comment, a sample measure there, looking at patients who are overweight who achieved at least a 5% reduction in weight. Why 5%? Because we know 5% is correlated both with better management of chronic disease, but also the prevention of chronic diseases within 9 to 12 months, and one could argue whether that's the right time frame as well. So again, the denominator is everyone eligible, and the numerator is the number of patients. And it's a way to track not just how many people are just screened for BMI, but how well are clinicians in partnership with patients, in partnership with community organizations, able to actually move the needle on the prevalence of a chronic disease risk factor. And I think that's the type of, I think, you look at sort of quality measurement moving forward, there's tremendous progress going from process to outcomes and patient satisfaction, but I think this component needs to be added to the mix. The third opportunity I see is really scaling what I call community-based prevention programs. So in this country, there are an array of programs outside the clinical setting that have significant evidence, whether to prevent falls or to manage chronic diseases or to promote physical activity. And these are oftentimes programs in group settings led by laypersons where there is an evidence base. And thousands are being helped across the country through these programs. Unfortunately, they're funded only through discretionary grant dollars or philanthropic dollars. And so when the need is sort of millions of Americans benefiting or beneficiaries, only thousands are. So one of the questions is why? And I think the answer is the lack of essentially a pathway to scaling these programs. So one of the, I think, the known programs over the last couple of years, which is probably a test case, is the diabetes prevention program that most of you are familiar with. So, this was a 2002 NIH clinical trial to really reduce the progression from prediabetes to diabetes through an intensive lifestyle behavior intervention. It was a successful clinical trial. The CDC and community-based partners like the YMCA translated this in a community setting. It was found that the progression was reduced even further in older adults. And so in about 2011, at the Innovation Center, we launched a model to test this out in Medicare beneficiaries. As a several-year model which showed savings. The CMS actuary actually signed off on this, and this was one of the few programs to date that CMMI has been able to scale. And of course, there are some administrative difficulties of that we can talk about. But even in that case, the bar, as you know, for CMMI was not only does it have to improve health outcomes, it has to reduce costs to the program, right? So that is a special bar. That is not a bar that if you are other interventions out there that could help beneficiaries have to meet. So if you're a drug, right, if you're a device in this country and you have a great idea to improve the health of the American public, you know the pathway there. You go to FDA, you have to get their safety and efficacy approval, and you come to CMS, to the coverage group here, and they will assess reasonable and necessary and determine whether CMS ought to pay for it. Private payers almost always follow. But if you're a community-based prevention program that's evidence-based, there is no pathway in this country. They are stuck. They are funded either through philanthropic dollars again or grant discretionary dollars. And really the CMMI pathway, it's important. It was important for the diabetes prevention program. But again, it's a bar that's really a double standard in the sense that, if you're a drug or a device or another clinical intervention that you don't have to meet. And so one of the ideas or proposed ideas is there ought to be a parallel regulatory pathway. Give regulatory authority either to a sister agency in HHS like CDC or AOA, they can assess the effectiveness. And in the same way, if it's deemed to meet a certain threshold, then that intervention should come to CMS for evaluation to assess whether it's reasonable and necessary so that more beneficiaries can access these programs and benefit from them. So another idea as we think about how do we invest and focus more on prevention that I want to put out there. So the fourth opportunity, and this is, I think, broader than, of course, CMS's purview, but it focuses on the $4 trillion federal budget. And the question that we ought to ask ourselves, can we find just a little bit of more money to invest in public health? And there are a series, here are 3 targeted public health investments that we ought to be making. Sort of the public health infrastructure in this country, important as part of our nation's infrastructure, is vastly underfunded. In fact, there's a $13 per capita gap, about $4.5 billion annually, in terms of public health not having the capabilities to assure the conditions that people can be healthy. And one of the recommendations has been there ought to be some sort of infrastructure fund, a public health infrastructure fund to support public health in this country. Another example is investing in community prevention, investing in states and localities. We did this with the Recovery Act and communities putting prevention to work about a decade ago. And these were resources and technical assistance that went into communities across the country. And in that case of that project focused on tobacco use as well as obesity, and there was significant success there. And then of course in public health emergency preparedness and response, this is probably central to COVID-19 and our response, the ability to have funding made available very quickly, both to support public health, but also to support sort of the medical surge response. And we can talk a little bit more about COVID-19 as well. So there are a number of, I think, targeted public health investments for which there are opportunities, again, evidence-based, targeted, that can make a real difference. And finally, sort of a fifth opportunity focused on prevention research. And if you look at our sort of biomedical enterprise in this country and even beyond sort of biomedical, the case can be made that we don't invest enough in prevention. So NIH, and again, I think when we talk about research, it's much broader than NIH, but NIH at $40 billion annually is a big piece of this. NIH's last assessment in 2012 that looked at how much research is going into prevention, they came up with a figure of 19%. Now, I don't know whether that's too high or too low, but I think it's good that there's actually been an estimate. But if you look at other estimates out there, if you look at NIH's nutrition research budget, if you look at NCI and their cancer prevention budget, when we know that half of cancers in this country are preventable, it appears to be pretty low. And I think there are some urgent areas of focus and attention, from basic biology of illness and prevention there, to behavior change, which is critical, to how you implement policy. So there are there's a lot of scope to really enhance our prevention research just across health and human services. And I would say I think this is critical also for CBO, as many of you know who are congressional experts here, that CBO, particularly their sort of scorecard and their scorekeeping, they look at 10-year budget windows. And the more research, the more data, the more evidence out there. Now, one can make the argument that that 10-year budget window is too short, ought to be longer, but nevertheless, the more data, more research out there, that will only help CBO better score prevention activities and increase the likelihood that Congress can be an effective player in building a culture of prevention in this country. So I want to end by just sort of reaffirming the fact that I think across CMS, whether it's payment policy, whether it's quality measurement, whether it's testing new models at the Innovation Center, there are so many opportunities. A lot has been done, and a lot of it, I know a lot of people are thinking about it, but there's a lot more that we could do, again, to build a culture of prevention in this country. And I think that it is critical. There's an urgency in terms of the population health trends. Through health care and through CMS, we're not going to do all of it, but the question is, I think for the agency, what is the role when it comes to prevention, and have we actually tackled all of the barriers that are faced, and have we taken advantage of all the opportunities out there? And so I'm very much looking forward to hearing your thoughts, and hopefully this was thought-provoking. I want to thank everybody again for taking the time to listen today, and hopefully this is an ongoing conversation that we can all partake in. Thanks, everybody.
All right, and now for part B of the presentation, I wanted to introduce to you Dr. Rena Duseja. Rena is our Chief Medical Officer of Quality Measurement, and Anand alluded to this earlier, which is how do we seize the opportunity to really bake in and better address preventive health. And I think as we look towards the future of value-focused care, measurement is an important and plays a critical role in actually, quality and value, quality and cost together, translating into value, and measurement's a critical part of that. So with that, I will introduce to you Dr. Rena Duseja.
Well, good afternoon, everyone. I see some familiar faces here in the audience, and it's great to speak to you today about CMS's efforts around prevention. And as Sherry mentioned, I'm the Chief Medical Officer of the Quality Measurement Group, so I'm going to focus a lot about how we're thinking about prevention in the framework of meaningful measures and our next steps forward. What I first want to stress is that here at the agency, prevention is incredibly important. There are many levers that we can actually push in thinking about our beneficiaries and their health. I recently actually got a report for our Medicare beneficiaries, and in that report it said that over 40% of our beneficiaries have one or more chronic conditions. And that's really critical as we think about how we are going to drive toward taking care of our beneficiaries in terms of how do they manage their chronic conditions, how do we actually drive toward preventing complications from them? And we've been thinking a lot about this from the measurement standpoint, so I look forward to sharing with you some of that. We also have other levers. So here at the agency, we have education and outreach, right, to our patients. And so we have educational tools such as the Preventive Services Educational Tool that we have listed here. And these are hyperlinks. If you have access to the slides, you can actually pull these up and see some of the information that we as an agency put forth toward our beneficiaries. And the other piece is around payment. And so many of the preventive services that are provided are at no cost to our beneficiaries. And that's really critically important if we're going to incentivize appropriate screenings, for example, for our beneficiaries. Or, for example, a patient who has diabetes, and how do we make sure they get their annual exam for screening for retinopathy, for example. And we also have outreach to our providers for education and outreach. So we have these articles of Medicare-covered preventive services, and this link shows kind of a series of things that are put forth through our Centers for Medicare around preventive care. So I'm going to pivot and talk about an area that actually I know a lot about because I've been at the in this group for about 3 years. I'm an emergency physician by background, and I will tell you, as someone who has practiced for many years, the critical importance of prevention for patients when they come into the emergency department. And you know, if you can really catch them before they have to come in to the emergency room and be admitted, for example, patient who again has diabetes and has to be admitted for DKA, and if they were actually seen at an earlier, more appropriate time and got the medications they needed, that we could have prevented that costly condition. So how do we tackle this in terms of quality measurement? Well, first and foremost, we really think about this in terms of measures as they apply to our value-based programs. And what you see in front of you right now is a framework for meaningful measures that we launched back in 2017. And this really was important for us to put forth because we were hearing from stakeholders that it was hard to understand how do our measures fit into the larger landscape of how we're improving quality of care for our beneficiaries. And I want to signal to you that if you look on the right-hand side here of the slide, there's 6 domains, but one of them is actually promoting effective prevention and treatment of chronic disease. And in that meaningful measurement area, we have 19 meaningful measurement areas in this framework, but one of them is around preventive care. And so when we did our analysis and our environmental scan of all the measures within our program, quite a few actually fell into this bucket of looking at, for example, what Dr. Frick mentioned earlier, around like tobacco screening, looking at alcohol screening, looking at, screening for opioid abuse, looking at how do we give the appropriate care for our patients with chronic heart disease or diabetes, and recognizing at that time that many of our measures were process measures. And how are we moving in the direction of really trying to incentivize outcome measures? And another real critical piece that I'll share with you is actually moving toward patient-reported outcome measures, which is the next iteration of our meaningful measures. And so this is actually something that we launched last week at CMS's Quality Conference, which is our Draft Meaningful Measures 2.0. And we're really looking for input on this framework. It's critical, I think, as you see at the very top, and we've outlined it, getting to the voice of the patient. And in that, box, I think it's important for us to think about how are we measuring those outcomes that matter to patients, but also drive toward value-based care. So you can imagine that we're actually looking at a patient's improvement over time for a chronic condition, such as, are we getting their HbA1c under control? Are we actually thinking about, like the example around obesity, and are we actually improving their BMI over time? So there's a commitment from our end, at least within our group, and we're hoping across the agency to increase the number of patient-reported outcomes. The Innovation Center was brought up earlier. There's a lot of work also there in terms of thinking about how do we measure things that matter to patients across alternative payment models? How can we get self-reported health for example, in terms of how patients assess their health? How do we think about healthy days? And there's ongoing work at the Innovation Center about trying to create a measure with that as well. So again, I think, the voice of the patient is absolutely critical as we also think about this in terms of the context of improving outcomes for our patients. And as you can see, the other 6 areas are around patient safety, chronic disease management, seamless communication through interoperability, affordability and efficiency, wellness and prevention, which I have that arrow to highlight, as well as behavioral health and substance disorders. And we know these are all intertwined, but I think it's really important to think through, like, how can we actually be looking at those overlaps, but actually smarter in our set of measures moving forward to drive to higher value of care. So I'm going to pause for a second here before I go on to some of the work we're doing. So how are we applying these measures into our value-based programs? I'll give you an example. Through the Quality Payment Program, we have MIPS, which is the Merit Incentive Payment System, which is one leg of the Quality Payment Program. And some of the work that we're doing right now is actually to align those categories that providers have to provide on, measurement on. So the quality measures, the cost measures, improvement activities, as well as promoting interoperability. And last year, we actually finalized in our rule an MVP framework. This framework actually allows for more of the alignment of the categories, but we're co-creating actually what these MVPs might look like within the program with clinical societies. And one of the things that we're hearing in our outreach sessions this year is the importance of actually measuring an MVP on prevention, looking at an MVP on multiple chronic conditions. And both of those actually, I think, while we recognize it's important, we're also stumbling on what measures can we actually capture on this. And we're recognizing not only that there might be some gaps, in particular around being able to capture that from the cost perspective, but also recognizing if we really are going to drive toward improving costs for our beneficiaries, to really look at this more holistically moving forward in our programs. We also do a lot of work with alignment with private payers, and what I want to share with you is some work that we're doing with the Core Quality Measure Collaborative. The Core Quality Measure Collaborative is an organization that has been around for about 3 to 4 years, has now recently transferred to being convened by the National Quality Forum, and federal agencies, including CMS, the VA, and DoD, is part of this collaborative along with private payers. And we're looking at the core sets of these areas that are listed here to think about, can we agree upon a set of measures across these areas? So for the last year, I think we're coming close to finalizing these sets around accountable care organizations, looking at in the outpatient setting measures around cardiology, gastroenterology, HIV and hepatitis C, medical oncology, OB and GYN, as well as orthopedics and pediatrics. And this next year, we're actually convening 2 more work groups looking at behavioral health and neurology. And there's many selection principles with we are convening to think about alignment, and I share these with you for you to see that we were integral actually in giving input into what these principles should be from the agency, but this actually informs even how we think about measurement in our federal programs, at least within CMS. And one of the most important things is really advancing health and healthcare improvement with stakeholder priorities. We also want to make sure that, our measures actually are, based on science, right? Scientifically sound, and the source of evidence is used to really be clearly defined as we're making the basis of a measure. And then, one of the things that we really have to balance is thinking about measurement burden along with innovation. Many of the discussions in the last year really had to do with, well, what's feasible in terms of what we can collect? But I think we have to move the conversation to what should we be doing in terms of improving care. I will tell you, for sitting in some of these work groups, that was a constant struggle among the people that were participating. It's easy to measure process, but it's harder to measure outcomes. But that's really where we need to be moving the envelope. Part of our Meaningful Measure, actually 2.0 strategy, is actually by 2030, we want to actually move to all our measures to be digitally captured. And what I mean by that is, like, we want not only the measures to be, abstracted from EHRs, but how can we leverage even patient-reported data on, how many steps are they, exercising per day? Like, what is their daily activity? Looking at, for example, a patient who has diabetes, what is their glucose levels? And how do we actually, or for example, measuring your blood pressure at home, which we know has proven to be, a better indicator than taking your blood pressure in an emergency department or in your doctor's office. So we're continuing to push that because we think we want to not only have reliable and valid data, but get data at that bedside or at that home to help inform care. And the other advantage is really to have measurements that actually can be timely and offer actionable feedback. And so that's some of the work that we're doing here at the agency and part of the discussions that we actually provide as we're interacting with the CQMC. And this speaks to a little bit what I just said in terms of, like, making sure these measures are really ambitious, and yet providers are being measured to something that can meaningfully influence the outcome and the intended level of attribution. Risk adjustment is a key issue that we hear a lot from our stakeholders, and we heard earlier about the importance of social, determinants or social needs, and how do they influence care. And, part of, from the perspective of our group, as we think about measurement science, and we have applied some of these factors into our risk models, as well as thinking about it from the program level, I don't think we actually have it right yet. And I think we know that ASPE is about to come up with another report and some advisement on how we should handle this. But part of it is a measurement problem and being able to collect data in a reliable way. We don't have right now the ability to calculate, for example, food insecurity. But should we be striving for that? Absolutely. Social isolation is another great example that was brought up earlier that we think a lot about. But when you're applying it into federal programs and quality measurement, we have to collect it in a way that is broadly applicable to the population that we're trying to measure. And I do hope, actually, as when we move in a direction of digitally capturing data through multiple mechanisms, through data sources, that perhaps we will be able to do that. And then, again, I mentioned the use of innovative measures and patient-reported outcome measures. There's been a lot of work at the agency in terms of thinking about across the centers if we can come up with a measure that really would be an indicator across our programs that we could keep in line with. So self-reported health is one good example. And we know that, for example, in some of our surveys that we are able to capture that. And we're hoping that we can, as we're looking at, if we only have a finite number of measures we can apply to our programs, to really think about which ones are the most meaningful in not only improving the care for our beneficiaries, but decreasing cost. And part of that effort really is on preventive care. So with that, I will stop because I know we want to have some time for a panel discussion and look forward to the conversation. Thank you. Oh. I actually had 2 more slides, but let me just, I apologize. I was eager to get to the panel discussion, but I just want to share for you guys, if when you look at the slides, that we do have an examples of preventive measures that went into the pediatric core set, so please take a look at these. And we also have an inventory tool here at CMS that shows all our measures across our programs, and the link is here. So this is an opportunity to see what measures are active and really through the whole continuum. Those are 2 resources to look at. Thanks.
Oh, it's working. This is good. Yes. So those of you in the audience, please come up here to ask your questions so people who are viewing by web are able to hear it. Okay, thanks.
Good afternoon. I'm Jacqueline Kreinick, and I'm a little shorter than this mic, so there we go. Number one is I want to thank Dr. Sherry Ling. You bring great topics as a geriatrician. I'm a nurse gerontologist. I'm in love with this presentation, so I hope the slides are available. There's a lot to comment about your presentations, both of you. But you're talking about prevention to a population that is trained in disease. They don't understand what you're talking about. They're allopaths who only look for the problem. They don't look for the healthy issue. Now, if you're talking about naturopathic medicine, if you're talking about functional medicine, then you're talking about people who know what health is about and how to help an individual maintain that health. But I think your measures and your education might need to be revised because you're talking to a population that really doesn't understand health. They are disease diagnosticians, they are disease-oriented, and we need to bring in other types of health providers to the table outside of allopathic medicine in order to get this conversation truly on board. But I still think your presentation was excellent, so I don't know how you want to comment on that.
It's really homeopathy, and I think it's sort of basic, sort of evidence-based science that needs to be on prevention. This is sort of mainstream. This isn't sort of, but I think that has not been taught effectively enough. At least it wasn't 20 years ago, and it may not be now. Because otherwise, you're right, providers will say, you know, we weren't really taught about all of that. We don't feel comfortable in engaging in prevention. So I would argue, my takeaway from your point is you're pointing out that the education of healthcare professionals is absolutely critical if we want to build a culture of prevention in the healthcare setting.
Right, so rather than waiting another 10 or 20 years for that educational system, there are people in the healthcare field who currently have that health orientation. I didn't mention homeopathy, but I do think that's a good sign. I said naturopathic medicine. So they're board certified, and there's, you know, all the credentialing at 4 universities in this country. I think now 6.
Sure, but the interventions, at least in my talk that I'm focused on, are not sort of naturopathic or homeopathic interventions. What I'm talking about are actually clinical interventions, or they're sort of community-based sort of public health interventions. And so absolutely, there's probably a role for lots of different healthcare professionals, but the ones that I focused on, actually clinically, clinicians today, you know, can do a better job on. And I would say sort of figuring out how the community preventions can be leveraged by clinicians is also something that could be done as well, I would argue.
And you only have one comment. When you put that slide up for pediatricians or pediatrics, when you're young and to a certain age, you have a milestone and a pathway to show what's good and what that healthy child should become. We have nothing for adults. And I mean, I specialize in growth and development, so I know it exists. So it's curious, maybe that's what needs to be like almost like, you know, you take your car in for a certain amount of miles, you get your tires rotated, and we don't have that for adults, so I don't think there are any real milestone markers to indicate what's the trigger point for possible risk factors that may lead into disease. And the other comment is there's never any conversation about stress reduction, and that's one of the biggest things for prevention. But I still think your presentations were excellent. I want to thank Dr. Ling, so thank you.
I just want to follow up on that. You know, it is disease-based in terms of our screening exams, and I think you make a point of further education and really moving toward team-based care. So, you know, beyond the clinicians, like thinking about our entire team and looking at some of these social needs and, you know, working with housing authorities, working with our social workers, and really being able to influence that care.
I'll just add sort of just one maybe tangible examples. This is sort of, so it feels like this is sort of within the world we live in. Think about older adults' falls. So in this country, older adults' falls are the leading cause of older adult injury death in the United States. 27,000 Americans who are older adults die from falls. It costs the Medicare program $31 billion every year to pay for these falls. It costs the Medicare program $36 billion to pay for cancer. So almost as much as we're paying for cancer, we're paying on falls. We know that most falls are preventable. We know that most falls happen in the home setting. We know that there are both clinical interventions, community-based programs, as well as home modifications to address those falls. And so back to the sort of the metrics discussion, right now, if you look at our quality metrics on falls, whether it's the annual wellness visit or APM metrics, it's focused on fall screening, which is great. The question is, how do we go beyond sort of just fall screening to increase accountability for the actual number of falls, right? Then we're actually talking about sort of prevention. We're going beyond sort of process, we're going to outcomes. So that's just sort of one tangible example. What we're talking about is absolutely within the domain of sort of clinical medicine as well as public health today.
I agree. I just think that there's, for someone who's been doing yoga for 25 years and Tai Chi, and there's enough stuff out there. What we're talking about is PFE, person-family engagement, okay? And I don't think a lot of clinicians either have the time, they're not reimbursed to train or to educate or to talk about this thing in depth so that the family or the individual elder can understand the value. I mean, I think you're right. I mean, I'm not disagreeing with you. I'm just saying it has to be more broadly expanded, and I hope it does. So thank you again.
So thank you as well. This was exciting to be able to think outside the box of where I spend most of my time. In thinking about the role of community and environmental and infrastructure, and then going back to focus on the metrics that we have within our program, it was exciting to me to hear an openness to, well, what should we really be looking at? And one of the things that I'd like to make a pitch for, I saw that you made a mention of aligning with other payers. The reality is that promoting physical activity in a 55-year-old is about preventing diabetes in the Medicare population over 10 years. So what are we doing to get data across all payers, not aligning with payers, but getting data across all payers? I was so excited by the discussion about Blue Button being an all-payer initiative, and I followed up with Andrea Oslanger after her presentation, and she was like, oh, no, CMS isn't getting all-payer claims. We're just creating a platform so patients can get all-payer data. But as an epidemiologist, we need it at CMS, or we can't drive our quality programs, and we need it not just for the Medicare beneficiaries now, but we need to know how the entire community is doing, because what's happening in the community affects the Medicare beneficiary population.
Thanks for that comment. I will say that part of our Meaningful Measurement 2.0 strategy is actually addressing this issue about the need to really expand our data to all payer data. Now, that's easier said than done. And it really, I think, will tie into some of these rules around interoperability and how do we get actually access to this data. But we know that, you know, even in our fee-for-service programs right now, that we're just getting a slice of what we're being able to measure. I don't know if any of you were able to listen to the grand plenary discussions at the quality conference last week, but we heard from David Kendrick about the importance of having data through HIEs, right? And how it really, if you miss data from one system, what actually are you measuring? So I think, at least from our group perspective, we are trying to push and move in that direction. Of course, that's going to take partnership with the private industry, with EHRs, with ONC and the federal government, but that is something that we have our eye on as well, at least, on how we can actually accurately and validly measure these outcomes for our patients.
Yeah, I would just add that I think when it comes to insurers, there's sometimes a collective action problem when you think about prevention. Somebody invests in prevention, then the beneficiary changes plans, changes Medicaid plan, changes to another MA plan, and then you don't reap the benefit. And I think the idea of sort of aligning quality metrics across payers so that everyone's got the same incentives. So even if somebody does leave and you get new members, they have sort of reaped the benefit from another insurer's policy. So I think to get away from that issue, I think sort of looking at it as sort of collective action, all insurers being in and aligning sort of prevention quality metrics could get around that.
Dr. Preck, always such a pleasure to see you. So you talked a lot about community prevention, and in an era of constrained resources, other than just pushing more resources to communities, how can we leverage programs at the federal level, like, for example, the area agencies on aging and other streams that already exist to do better prevention? And I think that that's a great example, because that's to some degree the Medicare population using senior centers, but some of these models are outdated and some of the activities that they're doing are outdated. So do you have any thoughts on existing federal streams and programs that could be better used to work towards prevention?
Yeah, well, I think the AAAs, or the area agencies on aging, are a great resource, and a lot of the programs that I mentioned above, you know, whether it's falls prevention or chronic disease self-management, a lot of these AAAs are offering them to their members. But having sort of a regulatory pathway that allows reimbursement of these programs, and I think the bar's got to be high, and the providers, the bar for the providers has to be high as well. But right now, there is no sort of reimbursement for these AAAs providing these evidence-based programs. I mean, they get some money from Administration on Aging, and there's some resources. But there is no sort of, you know, even though they're focused on Medicare beneficiaries, there's no payment from CMS to these places. So I just think that these programs have to be leveraged, and I think that payers can do that. Now, some of that's being done in the private sector, but thinking about how can Medicare do that? I think MA plans are doing it, but even traditional fee-for-service, I think setting up a regulatory pathway so that these interventions can be provided by AAAs to serve Medicare beneficiaries is one option.
Do we have any other final questions? Ellen. Hi, I'm Ellen. I'm going to build on what Jackie and Nancy were saying, and I've worked for CMS for 17 years, and I've thought this actually before I came to CMS because I was in long-term care. Medicare beneficiaries don't get these diseases when they become Medicare. They have them for years. So I like the fact that we're trying to think outside the box and work with other providers, but we really need to get at a young age. I mean, our obesity rates are extremely high in our children, which of course leads to diabetes and all that. And we need to take a holistic view on how to tackle this. It can't be Medicare, it can't be Medicaid. It's got to be many agencies and private in order to impact this. And we won't get to it until we do that, in my opinion.
Yeah, totally agree.
Great.
Yeah.
Okay, do we have any chat box questions? No? Nope. Oh, okay.
Hi, thank you so much. I was wondering if you could speak to a few of the housing programs that you mentioned with respect to United and Bon Secours. Anyway.
Yeah. So I think there's a series of sort of insurers as well as health systems that are now actually not just focused on home modifications and things, but are actually building affordable housing. Some using the low-income housing tax credit. So United, for example, has put in about $400 million over the last several years. Kaiser has just sort of made a $200 million announcement. So this idea of actually building affordable housing for a lot of the individuals that you see, I think is something that's new. I think particularly for the Medicaid population, where some of the needs are higher there. I think there's been a lot of focus there. I just think when you think about housing more broadly, there are so many opportunities there, whether it's affordability, whether it's accessibility, like falls, whether it's healthy homes, like asthma exacerbations. There's so many different angles you could look at. And I think if you compare all the sort of determinants and needs out there, where is the evidence base in terms of which ones in the shortest amount of time and potentially actually save money? I think housing is probably right up there, probably with nutrition, I would argue. So I think that's a Bon Secours is a little bit interesting. There are not a lot of hospitals out there that right next door have hundreds and hundreds of units, but it just goes to show you that there are folks thinking about this health housing.
So just one last comment that I think you addressed in your presentation. The nation as a whole has to decide what its moral value is, and so far it's not showing its best side. So can you comment on what can help the higher-ups really focus on what we as a people need from a healthy point of view?
Yeah, I mean, I think that's, I'll try my best with an answer, but I'm not sure if I'll have one. But I think that is the very question, and that's why I'm sort of just raising from a resource perspective. You do have to ask the question, where your resources are, reflects your priorities, reflects your values. And I think the question for all of us is, so I was on a panel, and now I can do this, I'm outside of government, but I was on a panel on the Hill a couple of weeks ago. The topic is what's missing from the healthcare 2020 debate. And so I said, well, health is. And I wasn't trying to be funny about that. The question is, financing health insurance coverage is absolutely critical, and that's how we do that. But at the end of the day, if the goal is to improve health, and better health is part of the mantra, then you got to look at prevention. And you got to focus on prevention, invest in prevention, think about prevention. So that is a tough sell in this environment, I think, to your point. How do you do that? But I think it starts with sort of education, laying down the urgency, laying out the evidence, laying out, some of the ways where you can get to, better health, better care, lower costs. But you may have.
I beg to differ. The goal was to reach the moon, and we did.
Yeah, that's true. That's true. So we're going to be optimistic.
Yes. So one thought for our audience as we depart back to our work is, we all have the opportunity to lead by example, lead from the front, as we say. So if you are able to, incorporate your routine healthy living into your daily lives, get enough sleep, keep your hands clean, get your flu shot, wear your seat belts. I mean, I point this out because these are behaviors we have just adapted to. So, this is both policy, but this is also culture and behavior. So I think this is also our responsibility. So I want to thank our speakers and also thank the audience for joining us today. Thank you.
Thank you.